Right. Let's get straight to it. When you're in that FRCS Viva hot seat and a topic like vasculitis or FMD comes up, listen closely. The examiners, well, we're not looking for a laundry list from a textbook. We are testing for a consultant-level mindset. Can you synthesize? Can you think on your feet? That's what we're going to nail down right now.
So here's our game plan. We're going to start with the core concept, what I call the inflammatory fire. Then we'll build out a proper systematic workup, the kind that shows you're a safe pair of hands. After that, we'll dive deep into the big players you absolutely must know, always with a surgeon's eye. And we'll wrap it all up with a take-home message that's going to stick with you, and more importantly, with your examiners.
Okay, first things first. This is the bedrock. Before you even dream about picking up a scalpel or planning a bypass, you have to get your head around the fundamental nature of the problem. This is non-negotiable.
Now, that's the formal definition, right? But what does it actually mean to us as surgeons? It means the problem isn't just a simple blockage. The vessel wall itself is sick. It's on fire, it's friable, it's angry, and it will not behave like a nice, stable atherosclerotic plaque. This is not a plumbing problem.
Now this right here, this is the single biggest trap candidates fall into. They see an occlusion and their brain just screams revascularize. They see themselves as plumbers. But your first job, your primary job, is to be a physician. You have to diagnose the type of fire. You have to classify it, because every single decision you make from that point on flows from that initial classification.
And here is your map for doing just that. The Chapel Hill classification is your absolute bedrock. You see, it sorts the chaos by one simple principle: the size of the vessel involved. Are we talking about the big pipes, the aorta, like in GCA or Takayasu's, or the medium arteries, or the tiny vessels that get hit in ANCA-associated disease? Knowing where the fire is burning in the vascular tree tells you almost everything you need to know.
Okay, so we've got the framework. Now let's build a proper, systematic diagnostic pathway. This is how you show the examiners that you think logically and safely, step by step. And this is the path. You don't jump to the fancy scan. You start with the basics. You listen to the patient. What are the red flags in their story? Then you get simple bloods to confirm there's an inflammatory process going on, your ESR, your CRP. Then you can start hunting for specific culprits with serology like ANCA. But often the real proof is in the pudding and you need a piece of tissue. And only then, at the end, do you use imaging to map out the full extent of the battlefield. It's a logical cascade.
You know, the history is where you strike gold. If an elderly patient tells you they have a new onset headache and it hurts to chew, that is giant cell arteritis until proven otherwise. End of story. A young woman who can't feel her radial pulse and gets tired arms, you've got to be thinking Takayasu's. These clues aren't subtle. They are massive, flashing neon signs.
So let's zoom in on those large vessel diseases, GCA and Takayasu's. This is a classic Viva pairing, and you need to be able to compare and contrast them flawlessly.
Look at how different they are. GCA, disease of the elderly, hits the arteries in the head and neck. Takayasu's, disease of the young, smacks the aorta and its main branches. Now, the surgical pearl for GCA is that this is a true medical emergency. You start high-dose steroids immediately. Don't wait for the biopsy. You start the steroids to save their vision, and then you have a window of about 2 weeks to get your temporal artery biopsy without the histology being affected.
And why the mad rush? Well, here's why. 15 to 20%. That's how many patients with untreated GCA suffer permanent, irreversible vision loss. You do not have the luxury of time. Your first and most powerful intervention is the prescription pad, not the scalpel.
Now, let's flip to Takayasu's. Here, the entire philosophy is different. Haste is your absolute enemy. The cardinal sin, the thing you must never do, is operate during the active inflammatory phase. If you put a graft onto a hot, inflamed aorta, it's a recipe for disaster. It'll thrombose, it'll fall apart. The rule is simple and absolute. Cool the fire with immunosuppressants before you even think about fixing the plumbing with a bypass.
All right, let's switch gears completely. Let's talk about two other crucial non-atherosclerotic diseases, Buerger's and FMD. People get these mixed up all the time, but they couldn't be more different. One is inflammatory, the other isn't. Once again, the patient in front of you tells you everything. You see a young man, a heavy smoker, with horrific pain in his fingers and toes, and you see those classic corkscrew collaterals on his angiogram, that's Buerger's. On the other hand, a young or middle-aged woman with baffling high blood pressure and her renal angiogram shows that string of beads pattern, That's FMD, and their management paths are on different planets.
For Buerger's disease, you need to be absolutely uncompromising. This is a disease of tobacco, full stop. Trying to do a bypass is almost always futile. The disease is in the tiny distal vessels. There's nothing to sew onto. Things like alloprost or sympathectomy, they're just buying a little bit of time. The only treatment that makes a difference, the only thing that works, is for them to stop smoking. Completely.
Now for FMD, the mantra is beautifully simple. Balloon, don't stent. The medial fibroplasia that causes the stenosis just pops open with simple balloon angioplasty. It works incredibly well. You rarely need a stent, which just adds its own set of potential problems. And remember this, FMD doesn't live in just one place. If you find it in the renal arteries, you have an obligation to look for it elsewhere, especially in the carotids. This brings me to a really crucial point about where we, as surgeons, fit into all this. For a lot of these diseases, especially the medium and small vessel types, we're not the star of the show, we're the supporting actor.
So when does the phone ring for us? Well, usually it's for one of three things. 1. Diagnosis. We're the ones getting that temporal artery biopsy. 2. Managing the downstream wreckage, the aneurysms, the critical ischemia. And 3, and this is probably the most important, knowing when not to operate. Behçet's disease is the absolute poster child for this. Because of pathergy, any suture line you put in is at a massive risk of blowing out into a pseudoaneurysm. Knowing to keep your hands in your pockets can literally save that patient's life.
Okay, let's cool all of this together. If an examiner leans forward and says, "Right, so summarize your entire philosophy for managing vasculitis for me," this is your answer.
It comes down to these 4 pillars. Number 1, diagnosis before destruction. You classify the fire first. Number 2, immunosuppression before intervention. You cool the inflammation before you cut. Number 3, the disease dictates the strategy. You don't treat Buerger's like FMD. It's a bespoke approach every time. And finally, number 4, the surgeon is part of an MDT. You are not a lone wolf. These complex patients require a team, and you work hand in glove with your rheumatology colleagues.
So, I'll leave you with this one question to frame all of your thinking. When you're faced with one of these complex, non-atherosclerotic diseases, what is your first instinct? Is it the scalpel, or is it the prescription pad? For the vast majority, the correct, safe, and life-saving answer is the prescription pad. Our surgical role is critical, yes, but it has to be thoughtful, it has to be well-timed, and it has to be guided by a deep, deep understanding of the fire we're trying to manage. That is how a consultant thinks.